Assalamu alaikum. Good morning, everyone. Today we're going to talk about carcinoma tongue. Tongue is a muscular structure that is lined by non-keratinized stratified squamous epithelium and is composed of 4 intrinsic and 4 extrinsic muscles that are separated by median fibrous lingual septum. While lymphatic drainage from the tongue is towards submandibular and upper cervical lymph nodes. As far as the carcinoma tongue is concerned, clinical diagnosis is usually easy. Early diagnosis lead to better treatment, and early symptoms make the patient to seek earlier medical advice. Though some patients they do present late, and most of the time they are either old and frail, or people using dentures or having pre-existing dental pathologies or problems, and most of the time they are correlating their new problem, that is carcinoma tongue, with their pre-existing pathologies or problems. Generally the incidence has been declining, but male to female ratio is around 2:1, that is more common according to some studies, and highest incidence is in India and France. The smoking, drinking alcohol, syphilis are common causative factors. Mostly the carcinoma of tongue involve middle third and over the lateral margin of tongue, that's in around 47% of cases, and due to its location it extends early to ventral aspect and floor of mouth as well, while posterior third of tongue involved in cancer in around 25% of cases and anterior third in 20%, while dorsum only in 4% of cases. Clinically it can present as early disease or maybe presented as a late one. In earlier presentation it would be in the form of exophytic growth with area of ulceration. Often they are painless, or they can present as an ulcer in the depth of a fissure, or it could present as an area of superficial ulceration but with unsuspected infiltration to underlying muscles. Leukoplakic patches may or may not be there. Asymptomatic, arising in atrophic depapillated area with erythroplakic or leukoplakic patches. While in cases of late presentation, they are more typical presented as malignant ulcer. It could be several centimeter in diameter and are hard in consistency. They could be having heaped up or everted edges. Most of the time the floor is granular, indurated, and usually readily bleed to touch or spontaneously, and there could be some areas of necrosis as well. Patient they do have pain at presentation, and that would be having radiation toward ears and neck, particularly if the lingual nerve is involved. Patient would have increasing difficulty with swallowing. Patient may have inability to articulate clearly, and patient may present with ankyloglossia, that is inability to protrude the tongue or to deviate to one side. Patient may present with fetor oris, that is excessive bad smell from the mouth. Patient may have dysphagia and may present with cervical lymph node enlargement. If we talk about the mode of spread of carcinoma tongue, it can present locally or through lymphatics or blood vessels, that's through bloodstream. If we talk about local spread, if the carcinoma tongue is involving anterior to third, it usually start on lateral margin and can reach to the floor of the mouth, extend across the midline, and may invade the mandible as well. While if the carcinoma is involving posterior one-third of the tongue, then it's usually spread laterally to the tonsils, then to the side of the pharynx, and even up toward the soft palate, or posteriorly extending toward the cervical spine and down into epiglottis or toward the larynx, or across to the other side of the tongue. While through lymphatics, metastasis to submandibular lymph nodes make resection of relevant segment of mandible mandatory. If anterior part of the floor is involved, bilateral spread to lymph nodes is common. While through bloodstream, more likely from posterior third than as compared to anterior third tumors, distant metastasis rarely manifests itself, and death occurs because of uncontrollable primary tumor or lymphatic spread. Now we'll discuss about investigation. The utmost and the best investigation is the surgical biopsy to confirm it histologically, and senile biopsy is recommended. MRI is the investigation of choice because it's an excellent modality that can differentiate and give excellent image of soft tissue infiltration, and it has as specific and as sensitivity as compared to CT in diagnosing cervical lymph node metastasis as well. If the patient presented with cervical lymph node enlargement, then FNAC of suspected lymph node should be performed to rule out metastasis. CT scan and plain radiograph both have a limited role in presence of MRI. Carcinoma of tongue is classified according to TNM classification, with T1 if the tumor size is less than 2 cm, T2 if it's 2 to 4 cm, if it's more than 4 cm, then it would be classified as T3, while if it's involving adjacent structures, then it's T4. Similarly, lymph node involvement, depending upon its size and site, it would be classified from N1 to N3, where N1 is if the tumor is ipsilateral single lymph node less than 3 cm, while in N3, any lymph node ipsilateral, contralateral, bilateral, but it would have a diameter more than 6 cm in size. While metastasis, either if the patient have metastasis, then it would be of course M1, and if there is no detectable distal metastasis, it would be labeled as M0. In the management of carcinoma tongue, the options are surgery, radiotherapy, or combination of both, depending upon the patient presentation. If the patient presented early with a T1 lesion that's less than 2 cm size, surgery is the primary treatment modality. So surgical excision of primary tumor should be performed with 2 cm margins in all planes. But if the patient presented with a lesion that is more than 2 cm, that would be if T2, hemiglossectomy should be performed at the least. While if the patient presented with T3 or T4 lesion, they're often involving floor of the mouth and alveolus, major resection of tongue, floor of the mouth and mandible is indicated. For these procedures, access is best via lip split and paramedian or median mandibulectomy or visor incision. Rim resection of mandible if tumor reaches alveolus. Total glossectomy if T4 tumor crosses midline need to be performed. Extensive defect followed by reconstruction with distance flap should be performed in cases of extensive resection. If tongue defect volume not more than 2/3, radial forearm flap is the best choice. But in cases of larger volume defect, like in cases of total glucectomy or when the section include hyoid bone, more bulky flaps are needed as rectus abdominis free flap or pec major flap. Resection should include neck dissection on same side of the tumor. Type of neck dissection depends upon the lymph node involvement. But in cases of advanced disease, should be combined with post-operative radiotherapy. Surgeon and radiotherapist should work together from the beginning. If the patient presents with large irresectable tumor or fixed large neck node, radiotherapy should be given. Though local resection of primary may make patient more comfortable, patient may have dysphagia, so might need nasogastric feeding or may need feeding gastrostomy. Patient may present with respiratory obstruction, so may need tracheostomy as well. Adequate analgesia and sedation with morphine would be required. Overall mortality at 5 years is constant despite advances in treatment, though prognosis is better for women as compared to men, where the 5-year survival in women is around 50%, but it's not even up to 25% in men over a period of 5 years. Survival rate is poor in patients who have history of smoking and drinking alcohol. Thank you very much for your attention. If you have any question, you can just post down in the comment. Thanks once again.